Good morning. So my job this morning is to talk to you about evaluation of neurogenic lower urinary tract dysfunction. So I like to use that term rather than neurogenic bladder because it's not just the bladder. I mean, it's the bladder and the bladder outlet. It's the entire lower urinary tract that's affected by neurologic disease or can be. So there's the bladder neck, which is a part of what I call the smooth sphincter, which is the smooth muscle of the bladder neck and proximal urethra. And there's what I call the strided sphincter, which is the strided muscle that's in the more distal part of the urethra that basically you contract when I tell you to stop voiding. So in order to qualify as neurogenic lower urinary tract dysfunction, there should be a relevant and identifiable neurologic condition. So you'll see something like this a few times today, I'm sure, in some of the other talks, just to give you an idea of what the incidence of lower urinary tract dysfunction is in these various neurologic diseases. So as you can see, it's actually quite high. So lower urinary tract function actually is, you can make it complicated or you can make it very simple. You know, I'm pretty simple-minded, so I like to make it very simple. And basically, there are two functions of the lower urinary tract, each of which can be affected by neurologic disease. One is the storage of urine at a low intravesical pressure. It assures continence and it also protects the upper tracts. The second is voluntary emptying at a low intravesical pressure. And neurologic disease can affect either one. And one of the things to remember about neurologic disease is, whereas in patients that have no identifiable neurologic disease or don't have neurologic disease, they usually present with symptoms. Patients with neurological disease, depending on the degree of their sensory impairment or the type of neurologic disease they have, they may actually not have any symptoms at all. So neurogenic lower urinary tract dysfunction, it's easier to abbreviate it because it takes too much space on the slide. So let's make it pretty simple. There's filling and storage, that's one phase. There's emptying and voiding, that's another phase. Neurogenic lower urinary tract dysfunction can affect either one or it can affect both at the same time. Obviously, a spinal cord injury patient, the typical thoracic spinal cord injury patient, has a failure of filling and storage because of detrusor overactivity and has a failure of emptying because of strided sphincter dysenergy. So it can affect both. So if you look at lower urinary tract function, there are a lot of disagreements about the physiology and the pharmacology that are involved, but I think that everybody would agree on certain general principles controlling the micturition cycle and its component parts. That's very simple, simple-minded, it's accurate, and these are used in the evaluation and treatment because any of these can be affected by neurologic disease. So bladder filling and urine storage really requires only three things. And basically, you look for these when you do your urodynamic study in a patient that has neurologic disease or not. One is a combination of increasing volumes of urine at a low intravesical pressure. That's called compliance with appropriate sensation. One is the bladder outlet that's closed at rest and stays that way during increases in intra-abdominal pressure. And the other is absence of involuntary bladder contractions, and the proper name for that now is detrusor overactivity, or DO. For emptying and voiding, it's pretty simple. Just forget for a moment the physiology or pharmacology that you think is involved. It involves a coordinated bladder contraction of significant magnitude, absence of anatomic obstruction, and also absence of functional obstruction. That is, it requires concomitant lowering of resistance at what I call the smooth sphincter and also the strided sphincter. So looking at a patient that has neurologic disease and possible lower urinary tract dysfunction, you know, what is it that basically you need to know about in your evaluation? Well, one is to remember that two-phase concept, and either or both can be affected. So what you're looking at is you're looking at the activity of the bladder, You're looking at the activity of the smooth sphincter, the smooth muscle of the bladder neck and proximal urethra. You're looking at the activity of the strided sphincter, and you're looking at sensation. Now, in looking at the patient that has neurogenic lower urinary tract dysfunction, you need to pay special attention to some things that you don't ordinarily pay attention to because you take them for granted. You know, one is how independent is the patient? How much mobility does the patient have? You know, is it easy for the patient to get to the bathroom? How much hand control does the patient have? Could the patient catheterize themselves if that was the obvious solution to their problem? One is their transferability. How easy is it for them to get to the toilet, especially if they're wheelchair bound? And finally, you know, what's the prognosis of their neurologic disease? Is it apt to be a stable condition, or is it apt to be something progressive? Because it's going to make a difference as to, you know, what kind of management strategy you propose to that person. This is what I think is a very good handout. It's the algorithm of the International Consultation on Incontinence. It's the initial management of neurogenic urinary incontinence, which is really what we're talking about. So basically, sort of in your mind, part of the history is, well, you know, if there's something identifiable, you know, what level is it at? Because that'll start you on the way to the hypothesis about what you think is going on. So is it a peripheral nerve lesion? Is it a suprasacral lesion? Is it a suprapontine lesion? So in other words, is it above here? Is it between here and here? Or is it a peripheral nerve lesion? And basically in the clinical assessment, you know, these are all the things that you want to elicit from the patient. I think it's a good list. The way that these algorithms were formed was the chairpersons of the individual committees get together at the end of the International Consultation on Incontinence, and the person who's the chair of the committee, so the person who is the chair of the Neurogenic committee, makes up these algorithms for initial management, specialized management, and then the entire committee, which is composed of the chairs of the individual committees, goes over each of these algorithms just to make sure that no one's opinion has been left out. So although they may be perfect, they represent a consensus of a number of people who basically deal with lower urinary tract function and dysfunction all the time. So you can look at clinical assessment, further history, general assessment, including their home circumstances, urinary diary and symptom score, assessment of functional ability, quality of life, and desire for treatment. You know, how much does the patient want treatment? How much do they want to be catheter-free, et cetera? What are they willing to do? A physical examination, which includes a neurologic examination, obviously urinalysis and a culture. Urinary tract imaging, the committee couldn't agree on what type of imaging, so serum creatinine and I think an ultrasound of the retroperitoneum is probably what we start with, and a post-void residual, basically. And this is still initial management, so once you go through that, it'll enable you to hypothesize what the problem is. Is it sphincteric incontinence, or is it urinary incontinence due to detrusor overactivity? And under the category of urinary incontinence due to detrusor overactivity, is it something that's associated with good emptying or something that's associated with poor emptying? Because that will affect what kind of treatment you propose. Now, you'll see that the urodynamic study is not in this algorithm up to this point. It's on the next two slides under specialist management. Now, personally, I think there's some room for disagreement here because I think rarely are you going to take a patient with a semi-complicated neurologic condition and do much of anything without some urodynamic studies to back up your hypothesis. So I'd be interested in hearing about that from the rest of the members of what's going to be up on the dais here, including Mike, about whether they would do that. And this is under specialized treatment. You can see whatever your hypothesis is and where you think the lesion is, the next thing is urodynamic testing, usually video urodynamics. Again, I think there's some room for argument about that, about whether you need to do a video urodynamic study on every patient. If you have it, does it give you additional information? Well, it does, you know, in some cases. In some cases, it doesn't add a lot. And again, we might be able to talk about that. And then on the basis of that, you should be able to arrive at a diagnosis that will either confirm your initial hypothesis or not as to what the urinary incontinence in the patient with neurologic disease is due to. Is it due just to straight detrusor overactivity? And if so, is there strided sphincter dyssynergia present or not? Is it due basically to poor bladder emptying, either due to detrusor underactivity or, again, usually strided sphincter dyssynergia? You know, usually the smooth sphincter is not dyssynergic except in patients with autonomic dysreflexia. And I think Mike is going to touch about that. Or is it strictly just stress incontinence due to a problem with the sphincter like you see in adult patients with myelomeningocele who have, you know, made the transition from pediatric urology to adult urology? And again, this is the rest of that algorithm that I think Mike is going to cover in his talk about how you actually manage these patients. And I think that if you understand everything on this algorithm, I think that you're pretty far along the track of understanding what your options are in a patient that has neurogenic lower urinary tract dysfunction. So these are all the symptoms that these patients can present with, or they may not present with any symptoms at all because they have, you know, altered or absent sensation. And these, on the right-hand side of the slide, these are the sequelae that you're looking for and hoping to prevent, assuming that they haven't occurred already. And the ones on the right-hand side, what you're looking to prevent, are generally associated with high-pressure storage, strided sphincter dyssynergia, DSSD, detrusor strided sphincter dyssynergia, and poor emptying. But remember that there are other things that about these particular patients that you have to take into consideration. Associated bowel and sexual symptoms. You know, you don't want to do anything that's going to make a bowel situation worse, and you certainly don't want to do anything that's going to make their sexual situation worse. And again, I had mentioned the limitations that some of these patients have that the ordinary non-neurogenic patient does not have. And again, I put in capital letters prognosis from the neurology service. So this is the neurourologic evaluation, which basically is no different in a patient with neurologic disease than a patient without, except that you do concentrate on the neurologic exam a bit more. And I think the urodynamic studies, with or without video, are perhaps more important. So just some personal thoughts about urodynamics in these patients, because my thoughts are perhaps a little different. I'm not so enmeshed in the details as I am in looking at the record and seeing if I can figure out what's going on. So this is my definition of urodynamics. And I think that the purpose of urodynamics, especially in these patients, is to classify a dysfunction in a very simple way. Do they fail to empty? Do they fail to store? Or do they do both? And whichever category they're in, is it due to bladder dysfunction, outlet dysfunction, or both? And I think that you can basically get that with a urodynamic study. You should be able to figure out all these things with a relatively simple, well-done urodynamic study. That is, which category the patient falls into. And to me, in a complicated neurologic case, that's really the main part of the evaluation. So generally, we spend more time doing it, looking at it, and thinking about it than we would in someone else. Now, the principles of urodynamics, you have to reproduce the abnormalities of the micturition cycle, and if the patient has complaints, you know, when they're applicable during the studies. And what you're trying to do is you're trying to provide a pathophysiologic explanation by correlating the abnormalities or what's happened to the patient with the urodynamic findings. Now, I find this very helpful. It's something I made up a long time ago. It puts urodynamics on 1/2 of one sheet of paper. Okay, if you're interested in bladder pressure during filling and storage, you do a filling systemetrogram, FCMG. If you're interested in detrusor leak point pressure, obviously you measure bladder pressure during filling and storage. If you want to look at the outlet during filling and storage, you know, that's not terribly easy to do. You can do it fluoroscopically. If the patient leaks, you can do an abdominal leak point pressure, Valsalva leak point pressure. Some people think that you can do it with urethral profilometry. I think it's a sort of a blunt, very blunt instrument that can do only a few things. In the emptying phase of micturition, you want to measure the detrusor pressure, you do a voiding systemetrogram, totally separate from filling and storage. If you want to look at the outlet during the emptying phase of micturition, you know, that's where fluoroscopy comes in handy. I think an EMG, the way we do it without a needle electrode, is somewhat inexact, and most of the time you get, or at least you interpret what you get as what you thought was going to happen initially. And the micturition urethral pressure profile, I just don't do because I've never been able to do one successfully. And flow and residual urine, you know, they're just the one study. What does it do? It just integrates the activity between the bladder and the outlet during the emptying phase of micturition. So if you have a normal flow and a negligible residual urine, and by normal flow I mean not only the rates, the pattern, it's doubtful that you have any problem with the emptying phase of micturition. Eric Rovner, who was with me for many years, made up this helpful hint to urodynamics, all the things that you're trying to measure. He calls it the 9 C's: contractions, compliance, coarse sensation, capacity, continence. Then on the emptying side, contractility, clinical obstruction, complete emptying, and coordination. So I think it's very useful, and you know, credit goes to Eric for making this up. It's actually in his book. He wrote a very nice book about urodynamic studies. So what's the role of urodynamics in a neurologic patient or anyone else? To identify or rule out factors contributing to the dysfunction, to get information about other aspects of their lower urinary tract function or dysfunction, and to be able to predict any adverse consequences of lower urinary tract dysfunction that you need to correct. To help you predict the outcome of some contemplated treatment you're thinking about. If you do urodynamics afterwards, after you institute a therapeutic modality, to confirm the effects of the intervention or understand the mode of action of what a particular treatment did or didn't do, and to try to understand maybe the reasons of failure of previous treatments for lower urinary tract dysfunction. This you'll hear about from Mike. You can look at the spinal cord and you can predict what's going to happen with lesions above the brainstem. You can predict what's going to happen between the brainstem and the sacral spinal cord, and you can sort of predict what's going to happen between the sacral spinal cord and the periphery. However, you know, it's been shown by many people, this is just a useful summary article that Roger Domachowski published a long time ago, that the presenting lower urinary tract symptoms, or what you think are the conditions or the problems, don't correlate very well with the type, extent, or level of neurologic injury or disease. So, and that even holds true in spinal cord injury patients, as I'm sure, you know, Mike will tell you in a couple minutes. So the management of these patients is really often dictated by urodynamics, and to me, that's the most important part of the evaluation, unless it's so simple. You know, someone has a stroke, they never had a problem before, they have urgency incontinence afterwards, they don't have a residual urine. I don't think you need to do urodynamics on those people. But somebody with a complicated neurologic issue, you know, especially somewhere between the brainstem and the sacral spinal cord, I think that those are the ones that benefit the most. So my commandments for urodynamics, that's Paul Abrams, okay, with the 10 commandments. The study's got to reproduce the clinical condition. If it doesn't, then it's worthless. Then you got to go back and do it over, even though, you know, there may be 4 other people on the schedule and you don't like to do that, you need to do it. You got to choose the appropriate study to reproduce the symptoms or the clinical condition. If the study's abnormal, but the abnormality seems unrelated to the primary symptom or clinical condition, which is not reproduced during the study, the abnormality may be the least likely is pertinent, okay? The most likely is clinically insignificant, and it may well be an artifact of the study. And actually, that's the thing that we see most often in patients that are sent with a complicated problem in a prior urodynamic study. You look at the record and the interpretation and say, I don't understand what's going on here, so we'd best repeat that. And remember, if you can get your information from a flow and residual urine, do it, because that's the best. This is Jerry Blavis's original diagram that was made very, very many years ago, but it's true. I mean, the more electronic instrumentation and the more interfaces that you introduce, the least likely is your record to be normal. And remember what Albert Einstein said about things that can be counted. So the urodynamic study will either support or deny your clinical impression. It's got to be interactive. You have to understand what you're doing, and the person who's doing the study, which may not be you, has to understand what you're doing. That's also maybe a topic for discussion in a neurologic patient. Do you need to do the study, or can you trust somebody you train to do the study and look at the results? And again, the urodynamic evaluation, I think, is going to lead you to what you want to do with respect to treatment. Are you going to have to treat the bladder, either as a reservoir or as something that empties, or you're going to have to treat the outlet? And there's a whole algorithm, basically of possible treatments. And what we do is we simply look down the algorithm. What's the algorithm for increasing bladder contractility? Well, unfortunately, it's pretty short because it doesn't exist. What's the algorithm for decreasing bladder contractility or treating overactive bladder? Well, there's a long algorithm for that, and so on and so on and so on for each one of the abnormalities that can occur under bladder and outlet. Now, one thing that's important, especially so with patients that have neurologic disease, is the follow-up. So the follow-up's critically important. It's really hard to shift the follow-up onto anybody but you if you're a urologist and you started out with the patient. I think the follow-up has to be at least yearly if the patient is so-called neurologically stable. And what is it that you're looking for in follow-ups, and therefore it's going to dictate the studies that you do. You're looking for infections and a history of episodes of sepsis, which means that probably your management could be improved. You're not doing something right. You're looking for deterioration of renal function, and you're looking for stones, which, depending on the type of neurologic disease or injury, can either be rare or uncommon or extremely common. And probably the most difficult situation for the endourologist and stone manager is a difficult calculus problem that occurs in somebody that's neurologically impaired. So that's all I have to say about evaluation. Thank you again, and I appreciate being invited to speak here.